Good evening, everyone. Welcome to this edition of Flavor of the Month. Standing on the World Glaucoma Month, we are presenting on one of the most important topics of glaucoma, the perimetry. I'm Dr. Vijay Anand from Agarwal's Chennai main hospital, and I am moderating and paneling this session along with the speaker, the most esteemed teacher of mine as well, Dr. Murali Ariga. He's a senior consultant too at Agarwal's Chennai main hospital, TTK Road. And he's a former head of Sundara Medical Foundation at Chennai, has many publications, both national and international, and a lot of trainings and awards to his credits. So he'll be starting the session with pitfalls and pearls in perimetry. So without much ado, we'll start the session. Dr. Murali, please.
Thank you, Dr. Vijay. Thank you for your kind introduction. And I think we'll get started. Thank you all for joining this evening. I know it's a busy week day, but I think somehow we have to fit in our academics into our practice as well. And this is an important topic and it's somewhat close to my heart because there's a lot of work which we have done in perimetry. And I thank, my sincere thanks to Dr. Preethi of the Clinical Education Board and other members of the Education Board, especially Dr. Sendil, who has been coordinating the whole program. And of course, I'm grateful to my colleague and associate, Dr. Vijay Anand at CME Chennai. So let's get started. And I think all of us use perimetry and all of us understand something about perimetry. And we are all still learning and trying to get the best out of a patient when we try to do a visual field test. A visual field test is a functional test, basically, and it is defined as that portion of the environment of an observer when you fixate on something which is steady. So you have to steadily fixate, and what you see around you is the visual field. So obviously, a simple answer is that when you don't fixate, you're not going to be estimating the visual field, which is why fixation and fixation loss is an important aspect of understanding why the perimetry depends on fixation. And of course, visual field testing is very useful for us, primarily in the diagnosis and management of glaucoma progression, and so on. Also very important in diagnosing neuro-ophthalmic disorders, and of course, certain retinal disorders. But primarily, I think I would say that most of us would use it 80% in glaucoma, about 10-20% neuro-ophthalmology, and maybe certain retinal diseases, retinitis pigmentosa, right, retinoschisis, and other indications in the macula, and so on. So these are definitions from the International Perimetric Society. The glaucoma definition is that it's an optic neuropathy. We all know that it's an optic neuropathy with very typical changes in the optic nerve. And there also has to be corresponding changes in the visual field. So this is also part of the diagnosis of what the glaucoma is all about. You must have something in the optic nerve. It must have typical changes. It must also correlate and have corresponding changes in the visual field. So it's part of the diagnosis of glaucoma, in which a field test is almost like a mandatory criteria for glaucoma diagnosis. But for glaucoma, of course, we use structural and functional tests. The functional test is what the patient does, and structural test is what we look at the optic nerve, the nerve fiber layer, and look at the OCT imaging and so on. So we need both for the definition and diagnosis of glaucoma. So we all know the extent of the visual field, and this is for the students, for completeness sake, that we really need to understand the extent of the visual field. One eye has to be covered, you fixate and you look around, and what you see above, below, and left and to the right, temporal, nasal side. Obviously, we're limited by the field because of the nose and the bridge of the nose on the nasal side. And the widest field of vision is lies to our temporal side. And tests for visual fields have actually evolved over time, over the last many decades. And we now have some really sophisticated instrumentation, equipment, technology, software, which helps us in analyzing the visual field and try to get the best out of a patient's test report. So we had the tangent screen, which is a flat screen kept a meter apart, and this was actually on the back of a door. And this was done for various. You see the color of the costume which the examiner is wearing, and the screen is black, and the stimulus is white, and so on. This is very popular till recently, until Hans Goldman brought in the manual perimeter called the Goldman perimeter, which is a ball perimeter. And this had a pantoscopic arm, and this had an illuminated ball, and the patient sits on one side, and the examiner testing the optometrist sits on the other side. And actually, there is some skill involved in doing these tests. We all started with these perimeters when we are postgraduates, and then gradually, we have all moved on to the small office-based perimeters, like the Humphrey and the Octopus and various other models of perimeters. The advantages of perimetry or automated perimeters are several. That is, you have a standardization, you can quantify the data, you can reproduce, you find the data is reproducible, can be stored and compared with previous test results. We have statistical analysis, and of course, we can do one test and compare with subsequent 4 or 5 other tests later on, and then monitor for progression and say, is it worsening, is it stable, and so on. So we don't need the perimeter for so many things. All of this is possible only with automation and computerization. And terminology in the automated static perimetry include what is called a static testing and threshold testing. So static means that the stimulus is static in one location in the visual field, and the alters or the characteristic is altered. As usually it is a brightness, and it is altered as dim and bright. Accordingly, the patient sees and doesn't see. And this is all about static perimetry. The stimulus at any given location is static, doesn't move, and its brightness is altered. So usually the brightness is the main thing that is altered. Sometimes we can alter the stimulus size and other things like color and background and so on, but usually it is the brightness. Whereas XY perimetry, like the Goldman manual perimetry, is actually when the target moves from non-seeing to seeing area, like confrontation perimetry, in which you move along the XY axis and you move from non-seeing to seeing area. Whereas Z-axis or Z-axis static perimetry is all about the perimetry, which is now currently done with automated perimetry and the computerized perimetry. We have a standard background illumination of about 31.5 apostles in most of the perimeters. We also have stimulus size of about Goldman size 3 or size 5. Usually it is Goldman size 3. And I'll explain to you why we have chosen the Goldman size 3 as the default stimulus size. And the stimulus is presented for a brief 100 to 200 milliseconds. And beyond that, there are various aspects why the stimulus duration should not exceed 100 or 200 milliseconds. And of course, the brightness is varied to estimate the threshold. So all of these parameters like the background, the stimulus size, and duration is kept constant for a machine. Only the brightness is varied. So all threshold estimation is about estimating and deciding which brightness the patient has seen or not seen. So for example, how to estimate the threshold sensitivity or a threshold at any given point. When you fixate, the patient fixates with one eye covered with the open eye into a fixation point, and do you see the stimulus? We start from a dim stimulus, you keep brightening the stimulus in several steps of 4 decibels or even 2 decibels, and keep brightening it till the patient sees, and then you cross the threshold again when the patient does not see it. So this is what we call a staircase strategy or bracketing strategy. So many methods we have to estimate to obtain what is called as the threshold. A very simple test is this. To estimate, for example, in one given point in the visual field, one location in the visual field, you present a particular stimulus of a particular brightness. Keep changing its characteristic, the brightness, till the patient sees or does not see, and you achieve what is called as a frequency of seeing curve, in which a particular brightness is shown, say, 100 times. The patient is likely to see it 50 times, and that is estimated as the threshold. So the higher the decibel value in terms of the sensitivity threshold, which is measured, it's a logarithmic unit. The dimmer is the stimulus, which means a 30 decibel stimulus is what the patient is likely to see. 30, 32, 34 may be seen at the fovea, whereas in the periphery of the visual field, the patients are not likely to see such bright dim stimuli. So dim stimuli are perceived in the fovea, which has the highest threshold sensitivity, whereas in the periphery, you will see say decibel values of 22, 24, 10, and so on. It is more towards the periphery. In the blind spot, of course, it will be 0 decibels. So you're not going to see anything in the blind spot. You don't really have to memorize or remember the normal values for each location in the visual field. The estimated threshold is actually in each location compared to the age match normal, and it is the location specific, it is age match, which is why the age has to be entered for perimetry, and without the age, the machine would not even proceed further, because all comparisons are with the database, which is compared with age match normal. So there's no need to really memorize values. A rough rule of thumb is that in the middle, so the most sensitive areas, you will get between say 30 and 32 or 34, depending on the patient's age and visual acuity and so on. The mid periphery, you may get between 25 and 30. And beyond that, you will get much less than that. So it's all rough rule of thumb, and the comparison is done with age match normals. It will tell you how much the expected deviation is there and how much the patient is actually deviated from expected normal. So don't really need to worry about the actual normal values. When you interpret a visual field, make sure you interpret systematically and stepwise. Of course, the patient data is the most important. Make sure you're reading the correct patient's field report, but sometimes field reports get switched and somebody else's field report gets into the file. So make sure you're reading the correct patient's field and ID and name and age and so on. And the second step is to see if the patient has done the test well, has fixated well. Is there false positives, false negatives? Generally, we accept about, say, 20-25% of fixation. Last 20% is what is ideal. And false positives and false negatives generally should not exceed 1/3. And of course, if the longer the test duration, then you know that patient has taken a longer time. On many of the field machines, will have a gaze graph at the bottom. That will tell you whether the patient has really fixated well and done the test to a satisfactory level or not. So reliability is very important. And after that, you look at what is called as the raw data, the numeric values, the actual thresholds measured. And we have a grayscale, which is extrapolation of the data in terms of 5 decibel steps to show you different colors, dark and gray areas and dark areas. This is useful to explain the sort of field loss which the patient is experiencing to the patient and the relatives, but not really useful from a ophthalmologist perspective. The total and pattern deviation, of course, is number 5 and number 6 here in the stepwise interpretation. And the total is, of course, the expected, how much the patient has deviated from expected threshold values. And the pattern deviation takes off generalized depression like cataract, media opacity, refractive errors, and so on, and gives you what is the underlying field defect. Something like you have cataract with glaucoma, the pattern deviation will show you the exact extent and how dense the scotoma is and so on. Then we have the probability plots, the MD and the PSD. We also have what is called as the statistical indices, called the visual field index. It is a single number. The visual field index actually is an oversimplification of the visual field data. It will give you the entire, like scoring an exam and write the marks, and the marks for an exam. You get 100%, you are completely okay. You get about 80%, you are fair. So you get 60%, you're not done well. So visual field index is an oversimplification, but the visual field index, I'll come to that in the next few slides. The VFI is a very important parameter for monitoring progression with the new software. So VFI is an important parameter. Then you have the glaucoma hemifield test, which is usually abnormal. In this particular example, also, you will find the GHT is outside normal limits. And then once a field is abnormal, you have decided the field is abnormal based on certain criteria, you have to decide, is it glaucoma or not? Or is it any particular disease pattern or not? And does it correlate clinically or not? Having an abnormal field does not mean it is glaucoma. Having a field which looks like glaucoma does not mean it is glaucoma until it is correlated with the patient's clinical history and entire data and everything else together. So one single output like a visual field alone is obviously not enough. Certain other machines like the Octopus are also available. And you have in this slight difference from the Humphrey in that some of this output the grayscale can actually be generated in color. Instead of total deviation, it's called comparison. Instead of pattern deviation, it's called corrected comparison. The probability plots have a similar interpretation with p-values. And there's something called as a defect curve, in which the least deviated value is to the left, the most deviated value is to the right. And this has to lie within this BB's curve, or the defect curve, as we call it. And there's a ranking about, suppose, let us say in the G program of the Octopus, 59 points are tested. The least deviated rank number 1 is on the left. The most deviated rank number 59 is on the right. And you also have the statistical indices called as the MD, the loss variance, and corrected loss variance, which is the equivalent of the PSD and MD of the Humphrey. In the Octopus, what you will find, the reliability is mainly judged by the false positives and false negatives. There will be no fixation loss, which is mentioned in the printout, because fixation loss, when the patient loses fixation on an Octopus perimeter, the stimulus is not presented, which is why the perimeter is probably more useful in reliability, because once the patient looks away and does not look at the fixation, there is no fixation loss which is monitored because the stimulus is not presented at all, which is why this is a slightly superior perimeter in terms of getting a better outcome for the visual field. Also, the test pattern is slightly different in the Octopus as compared to the Humphrey perimeters. You will see more closer test patterns in the glaucoma specific areas in the central field as compared to the Humphrey's 24-2 and 30-2, in which the test patterns are broadly into 6 degrees apart all over the tested area. Whereas in the G program, which is glaucoma specific, the testing pattern is more specific for picking up glaucoma change. What you must remember about perimetry, the most important thing is that the instruction to the patient has to be done. Be patient with the patient and make sure you give a demo test to the patient and explain what is expected, how it is done. Because most of them are intimidated by a machine, by a computer, what test is going to be done, what is the outcome, how does it my disease is going to be managed. They all have their own anxiety and fear. So we have to put them at ease and make sure we have a good calibrated machine that is checked periodically. Proper demo instruction and video should be explained to the patient. And then the perimetrist or whoever is doing the test, the optometrist, has to be encouraging. We should not look away and get distracted and look at their mobiles when the patient is doing the test. See how this particular patient has been positioned and placed without the forehead even touching there and the chin pointing up. And so this is not the way a test should be done. So make sure we do a proper test with a proper instruction. And generally, a first test is usually a trial or a demo test for a patient. A second test onwards is what we use for even subsequent comparisons. A subjective test, proper instruction, encouraging test, and silent, calm room and dimly lit room is preferable for doing and getting an optimum outcome. So the fixation loss, as I already mentioned, if the patient does not fixate on the central fixation target and then start pressing on the button when the dim or bright stimulus is presented, the loss of fixation can actually result in a lot of artifact-like defects which are coming up. So fixation loss is key to perimetry, and we should really encourage this. And by instructing the patient to look in the center of fixation, press the button when the dim or bright stimulus is seen at any different location in the visual field. And as they press the button, we generally instruct the patient to blink. Suppose the patient does not blink and keeps staring into the perimeter machine, they'll find that they get fatigued out, they get anxious as to where the next one is coming, the next stimulus is coming. So we generally instruct the patient to look at the fixation. The moment they see a stimulus and respond, even if it's a dim stimulus, they have to respond. Sometimes they don't respond to dim stimuli. They only think the bright ones you have to respond. So dim stimuli also they have to respond. As they press the button, they have to blink. Unless they blink, that fatigue, tiredness, and burning sensation comes in. So it's very important to instruct the patient about fixation and about blinking and about they're doing a test in a relaxed manner. And also placing this trial, the full aperture lenses have to be placed for refraction. Make sure a reasonable amount of cylindrical correction or spherical equivalent is also placed for the trial lens. It has to be full aperture lens. It has to be kept reasonably close and not too far away from the patient's eye. It should not touch the eyelashes, and the placement is extremely important because the higher the refractive error, the more the chance of rim artifacts are going to come in perimetry. And also you will find people with high myopia and aphakia, very high, say, refractive errors are more than 6 or more than that. I would generally like to do the visual field with a contact lens in place. That will actually give a better visual field test outcome rather than putting in these kind of trial lenses for high refractive errors, especially aphakia and high myopia. Also, you will find that the eye patch position when you cover one eye, many of us were in a hurry, we put a small bit of tape or we stick the eyelash, we put a bit of cotton or gauze, we don't place it properly. The patient is uncomfortable, and look at this particular example where the cord is obstructing the tested eye. So make sure patient is comfortable, make sure the test is being done at the patch in correct position. And also when the patient is fixating in the center, the pupil center has to be in the center of the Mayas, which the perimetrist or optometrist is doing. If you're having an off-center pupil position, it will not be optimum and you're not going to get ideal threshold measurements when the pupil center is not there. So the machine would itself indicate that is off-center, and patient can be asked to reposition and recenter the pupil. The age is extremely important, as I already mentioned, that if you don't put in the correct age or put in the wrong age, for example, if you're testing an 80-year-old and you put as 58 years old, it will be comparing with a 58-year-old and the field will look really bad. Similarly, if you're doing a young patient and put an older age, it will look like it's much better. So, but the age has to be entered, the correct age has to be entered, and for subsequent comparisons also, the age has to be accurately. Ideally, you should put in the date of birth, so the machine can actually calculate the age and look at subsequent comparisons also. The lens rim artifact, as I mentioned, the placement of the trial lens is extremely important. We'll get trial lens rim artifacts like this if the trial lenses are not placed optimally. And also the facial structure like blepharotosis and other eyelid abnormalities and drooping of the eyelid, dermatochalasis, all of this can actually cause scotomas like this, and you can actually tape up the eyelid for the patient's comfort, put in a lubricant, make the patient blink a couple of times, and taping it up can actually ensure you get a good visual field test report. The pupil size is also important. We can actually do perimetry if the patient can be dilated. There's no angle closure, no contraindication to dilatation. Perimetry can be done in dilated pupils also, but every time you do the field, the same pupil size has to be there for comparing one field versus the other. A pupil generally less than 3 millimeters, perimetry is not going to be useful. Very myotic pupils, you can even dilate the pupil and do the perimetry. But every time the same ideal pupil size of the previous and next one should be there. A 3.5 or 4 millimeter pupil would be ideal for doing a good perimetry. Pilocarp, some patients are on pilocarpine, so you will find a pilocarpine effect can cause a constricted field with decreased thresholds, dilate such pupils, provided there is no contraindication to dilating the patient. A learning effect, all of us do these tests with some anxiety, so we don't know how to sit and where what kind of response we have, the patient has to be doing the test, and all of us have difficulty. It's a very uncomfortable test, basically. So once the first test is done, we generally use it as a learning test, a trial test, and second test and third test is what you see the example of even a normal patient with normal vision. There's a strong learning effect or practice effect from the first to the subsequent test. Second and third test onwards, patients start doing it much better. So they understand how to do it, they get confidence and they start doing it better. So don't be in a hurry to diagnose and manage a patient with just one single field test. Make sure it is repeatable, make sure it is done a couple of times. Don't be in a hurry to operate on the patient and start treatment until you really get a clear picture of what is going on. Fatigue is also very important. If you're going to do a test which is going to take 10 minutes or 15 minutes, obviously anybody would get fatigued, and the fatigue will start affecting the thresholds and the visibility of the stimuli. So fatigue, that is why we have all switched to the CETA and CETA standard and CETA fast and so on. CETA standard is probably the ideal default test for perimetry and the Humphrey. It is a minimum or sort of a compromise between the test duration, fatigue for the patient, as well as getting an optimum outcome. So CETA standard would probably be the ideal kind of test to counter this kind of fatigue effect on the visual field. So what are the key parameters in perimetry? We have what is called as fixed variables, and you have variable parameters. The fixed parameters, like I mentioned already, you have fixed background intensity, you have a standard color, say, white on white perimetry as we call it. We have a maximum stimulus luminance, and we also have a stimulus duration. These are all kept fixed. They're not really going to change when you're doing tests for this patient. So patient-specific parameters, that no one parameter will fit all patients. But what we can change is that in perimetry, in automated perimetry, the modern ones all use static. So there is no question of kinetic. Some of the perimeters like the octopus, the modern octopus perimeter, also has what is called as a kinetic perimetry option, automated kinetic perimetry option. The Humphrey does not have that. The type of stimulus is generally a white on white. It is function specific, can be changed for low vision if the patient has low vision. The test pattern, the test strategy, the type of stimulus can all be altered and varied for any given eye of a patient. So generally, the testing strategies, you must remember the suprathreshold tests are not useful in practice today, whether it's neuroophthalmic, glaucoma, retina. We don't use suprathreshold tests at all. Threshold tests were used in the past to the older models. We still don't do threshold related tests anymore. Full threshold tests are very time consuming, fatiguing, and for the time the patient is done for doing the test, a lot of energy is wasted and you don't get optimum results with the full threshold. So by default, as I already mentioned, you're going to do what is called as a CETA, Swedish Interactive Threshold Algorithm. This is called as efficient threshold testing. And CETA, we have what is called as the CETA standard, and we have CETA fast. I'll come to that in the next few slides. In the octopus, we have what is called as the dynamic, and we also have the tendency-oriented perimetry. The top program of the octopus is equivalent of CETA fast. The dynamic program of the octopus is the equivalent of the CETA standard. Basically similar type, but the outcomes are going to be the same. So this is an example of what is a full threshold perimetry for a patient. Will take about 10 to 12 minutes of test time. And dynamic test, which is the equivalent of CETA, will take about 6 to 8 minutes on the octopus. Whereas you look at the top or tendency-oriented perimetry, you will get almost similar. There is some compromise in the test which is acquired. You will find some shallowing and some kind of blunting of the scotoma, but you're still getting enough information in 2 to 4 minutes as compared to 10 to 12 minutes. You're getting enough information with even a top strategy. So a dynamic is good, top is enough. Normal really takes too much of time. We don't really do. This is all for the octopus. In the Humphrey machine, you have A full threshold test, the 30-2 can take up to 14 minutes, whereas a CETA standard 30-2 will take 8 minutes. A 24-2 CETA standard will take about 4 minutes for a normal visual field and 3 minutes with the CETA fast. So CETA standard is the best compromise for time and accuracy. I think we should all stick to 24-2 CETA standard as the default strategy. You can, of course, modify for certain patients. CETA fast, by mind you, is not a good screening test. People might think you want to do it quickly and you want to do a fast screening test, you do a CETA fast. CETA fast takes some learning and takes some patient to understand every aspect of the perimetry. So somebody who has been doing the visual field for several times, then you can start doing and following up on CETA fast. So a single test for the patient for the first time, ideally you should do what is called the CETA standard 24-2. We also have what is the newer strategy called the CETA faster, which is now available. CETA standard has been there in the past. CETA fast is available. CETA faster does it with an even faster strategy and takes much less time than before. So it's about 50% faster. This picture is from the website of Zeiss. So some of us are questioned, and many students ask us about why don't we test the entire extent of the visual field? Why are we testing only central 30 degrees? Why are we testing only central 24 degrees of the visual field? The central 30 degrees of the visual field actually covers about 66% of most ganglion cells and corresponds to about 83% of the visual cortex. So even for neuro-ophthalmology, a 30-2 is more than sufficient. We don't need a 60-4, we don't need a 60-2. Those kind of extensive testing is not necessary. For central 30 degrees is actually more than enough for all of our diagnostic requirements. In glaucoma, we often do 30-2 or 24-2. Neurological also 30-2 or 24-2, except when you have a small central scotoma and a patient who has a near normal visual acuity, but suggests optic neuritis, straight away you can start with the 10-2. And for peripheral retinal detachments, distinguish between detachment and retinoschisis, then probably you can think of doing certain custom tests like retinal diseases. You can do peripheral retinal testing. But the exception, this is the exception. Usually it is the 24-2 or the 30-2. And 76 points are tested versus 54 points are tested in 30-2 versus the 24-2. So you will find that if the edge points of a 24-2 are actually important. Do not ignore edge points on the 24-2. This is an example of a field in which the GHT is borderline, everything looks okay, but the pattern deviation is showing plots, spots and scotoma like dots in the periphery. So don't ignore this. When you have a doubt about such a field defect, even though it looks borderline, this 30-2, the same patient shows you an outside normal limit GHT, and you can look at a scotoma-like picture emerges when you do a 30-2. So do not ignore edge points on a 24-2. It is important to look at the edge points also. When you strongly suspect there's something going on, you see it on the optic nerve, but you don't see it on the visual field. When the visual field defect is close to fixation, you need to test the central 10 degrees. Why? Because with the 24-2, you're actually looking at 6-degree pattern testing points, and you tend to miss what is happening in the central visual field. Whereas the 10-2 visual field will actually look at 68 points with a 2 degrees test distance between points. So you're actually zooming into the center of this visual field. Getting more information, which is far more useful for us to know. Is there a split in the fixation? Is the central field involved for prognostication and for also documenting whether any change is happening when any therapeutic intervention is being planned? To do a 10-2 as well, along with the 24-2. You can also follow up with the 10-2 in the future. The 24-2C, I think many of you are aware that it's a hybrid of the 24-2 and the 10 degree 10-2 pattern. What it does is it adds 10 points of the 10 degree testing pattern to the 24-2 and is what is called as a 24-2C. This is the 24-2C faster program of the Humphrey's new software. It is available, and when it first came in, we were all quite sort of enthusiastic and excited about this picking up more points than the 24-2. However, we don't really find that it's giving that extra information, but it's useful when you find that you have a little nerve fiber defect and you find a notch in the rim. The 24-2 or 30-2 is completely normal. Then you can actually look at this 24-2C, which is a faster program. Or ideally, you can even go and do what is called The 10-2 gives you a little more information about the central visual field. The macula program is a central 5 degrees which is tested with 16 points. Each of these points are tested twice, and the central 5 degrees is tested. This is very useful for, again, advanced glaucomas looking for split fixation, and also we can use it for drug toxicity and looking at scotomas and optic neuritis and so on. So not usually done always. 24-2 is enough. The 10-2 and when the central field is involved. The macula program, again, you can look at in specific areas where you want to look for the central 5 degrees of the visual field. The coming to the Goldman sizes, Goldman very cleverly devised these sizes which are from size 1 to size 5. And the size 5 is a large stimulus size. Size 4 is next. Size 3 is, this is the size in relation to the blind spot. And he defined the perimetric stimuli sizes. And each step actually corresponds to a change in the diameter by a factor of 2 and an area by a factor of 4. The size 3 is actually several times smaller than the blind spot and hence was considered to be an accurate measurement size. And now by default strategy, all perimeters use the size 3 Goldman. Occasionally, you can use a size 5 in the Humphrey when you want to look at an advanced field like this. You will find the field on the left side, 30-2, is giving us no useful information with a completely black area here. So what you can do is when you get this kind of information, the size 3, this is the size 3 stimulus, and we go in and test the same field, the size 5, you get a little more information on what is going on in the visual field of the patient. This is useful to know what is going on. At the same time, patient may be having 6/6 or 6/9 vision or 6/24 vision. So this is useful to know what is the extent of the visual field loss, whereas a black field like this is not giving us any information. So in an occasional patient, you can use a similar size 5 when the patient has extensive field loss like this. The visual field index is a new summary of the visual field status expressed as percentage of normal age adjusted VF. It is center weighted to correlate with ganglion cell density and visual function, is less affected by cataract and media changes, and is optimized for progression. Suppose you want to look at the trend over time, the visual field index is very useful. So visual field index is the relatively new summary of the visual field status. So we do really need to understand what is the VFI. And this is the progression analysis using the VFI. And the projected trend over next 5 years is the patient likely to deteriorate. To look at this VFI trend, the rate of progression, you can actually start extrapolating and guess that this patient is going to get worse over the next 5 years. So is the field abnormal or not? A cluster of 3 or more non-edge points on pattern deviation, one of them depressed to less than 1% of what occurs in normals, the PST of what occurs in less than 5% of normals, GHT outside normal limits, but these tests have to be repeatable at least once or twice. A repeatable abnormality is what makes the Anderson's criteria as the field being abnormal. If the field is abnormal, and the glaucoma hemifield test, which is actually comparing 5 clusters of points above and below the horizontal, it can be labeled as normal, borderline, generalized reduction, and abnormal. So these 5 clusters above and below the horizontal are very important for a glaucoma-specific diagnosis. If the GHT is abnormal, it's more likely or very much likely that it's possibly abnormal field due to glaucoma. The octopus does things a little differently, and what is tested with, there is no GHT in octopus. The cluster analysis is done for different test patterns. This is the G pattern on the left side. The 30-2 or the 32 program, there is a program like that in the octopus as well. And a 24-2 also is available. Each cluster of points is analyzed, and the cluster analysis is available with the octopus. And each cluster can be followed up for progression. That's what we call as a cluster analysis, and cluster analysis for progression can be monitored using the octopus machine. Octopus is the cluster is a unique feature of the octopus. So is it glaucoma or not? So the visual field defect in glaucoma usually follows an arcuate pattern corresponding to the pattern of nerve fiber layer bundle loss. It is asymmetrical across the horizontal. It is located in the mid periphery in early and moderate cases. It is about 5 to 25 degrees from fixation and has to be reproducible and not attributed to any other pathology like a scar or a laser mark or an old BR view or a treated area or a macular scar and something like that. All of this has to be understood before we adopt this as glaucoma. It is usually clustered or localized to neighboring test points, should correlate to the appearance of the optic nerve. But you have a completely normal looking optic nerve, no defect, no rim loss, completely healthy looking optic disc, then your field defect obviously does not correlate at all. So you need to have it correlate. does not affect the visual acuity generally in glaucoma, except in a very advanced glaucomatous optic atrophy, or there's a presence of coexistent disease like cataract or macular disease and so on. So generally, glaucoma patients will not come and tell you that I can't see. Generally, they'll walk in and bump into objects, have difficulty in driving, and have accidents and so on. But they will not tell you that they don't see. Unlike the positive scotoma of cerebrovascular accident, like stroke, they'll clearly come in and tell you, I can't see on the left side or I can't see on the right side. There's no glaucoma patient unless very, very advanced visual loss. They will not come and tell you that they don't see, and the small arcuate scotomas and paracentral scotomas don't really affect them in a sense that they come in and tell you that they have a field loss. Look at this typical example of a visual field loss with a scotoma, which is here, and correlates with the dark area of a nerve fiber layer loss in the superior area. This has to correlate. Suppose you accidentally miss this kind of a scotoma, the RNFL defect, you see it on the field, you suspect something, pressure is 26 and you've done a visual field and you pick it up like this, go back and see it on the disc, which is why we said disc documentation is important. Document disc photographs, do a visual field, look at the change on the disc and structural change over time, and keep monitoring for change in the visual field. How do you decide is it cataract or glaucoma or both? Suppose it's only a generalized depression and the total deviation is showing it, the pattern deviation is not showing it. This is more likely to be a generalized depression due to some media opacity or high refractive error and so on. Whereas if you have generalized depression, like on the total deviation, you also see it on the pattern deviation, and the underlying defect is what is picked up as glaucoma. This is possibly a cataract with glaucoma. This is probably just a cataract. A few examples of typical field defects before I close. This is a classic for the exam for the benefit of students whom I have joined. A typical example of a paracentral visual field defect is what in most exams they will ask. That the paracentral field defect is the earliest sign of a field defect in glaucoma. Paracentral visual field defect comes like this. This is an arcuate scotoma in which it joins with the blind spot. It gives you a typical arcuate kind of scotoma. You see all the parameters are abnormal, including the GST is abnormal. This is a classic nasal step. Because of the asymmetry between the two hemifields, you get the nasal step here. And superior and inferior arcuate visual field defects, which are becoming a double arcuate kind of a scotoma. This is also a typical example of glaucomatous field defects. Non-glaucomatous field defects is a no-brainer for you to see. There's obviously non-glaucoma. You're going to have something which is complete altitudinal kind of, when you have a typical clinical picture with a visual loss of an AON. We don't really need too much of data for us to say this is not glaucoma. And similarly, this is also simply straightforward, which tells you that the vertical meridian is being obeyed, and you find the field loss is so typical and symmetrical between the two eyes. But you will find that you tend to miss these kind of defects. Whereas ophthalmologists, we have to understand is that keep both the fields side by side and do not miss the symmetrical field defects. For example, you may think if you look at only the left or the right eye field, this looks like an arcuate scotoma or a nasal step. This looks abnormal like an early arcuate scotoma. But if you keep both side by side, what is called as a 2-on-1 printout or a 2-on-1 printout, we sometimes get to the octopus. Keep both fields together and view it together. That is when we suspect there's something going on in the visual field, and you should not miss a neurophthal lesion. Very often we miss neurophthal lesions. We dub this as normal tension glaucoma and treating you with eye drops. Like these kind of things are very easy to diagnose, whereas these kind of field tests you should not miss. Look for asymmetry or symmetry and keep your index of suspicion high. You have nothing else which fits into the diagnosis. The disc does not look suspicious. The patient's IOP is in the normal range. Think of something else. So in the diagnosis and follow-up of glaucoma, early detection is done using structural tests like the disc and RNFL analyzers like the OCT and so on. Functional tests like blue aneloperimetry, flicker have been used in the past. But with the advent of the OCT, we no longer use blue aneloperimetry. In the screening, diagnosis, and follow-up of glaucoma, we use white-on-white perimetry, like the CETA standard, CETA fast, and so on. And the octopus, we have the normal strategy, dynamic top, and which you already mentioned. In end-stage glaucoma, structural tests like OCT are not of much use because you already reached the floor effect. Perimetric tests can be useful. You can use low vision strategies in perimetry using, like I mentioned, about the size 5 stimulus, using a large diamond for fixation and so on. So structural tests are not of much use in end-stage advanced glaucomas. Use perimetry. Consider kinetic perimetry if you have an octopus perimeter with your kinetic perimetry option. Kinetic perimetry option of the octopus is quite useful for end-stage advanced glaucomas. Perimetry more useful in moderate and advanced glaucomas. In early glaucomas, use structural tests and tests like OCT and in the mid-range of mild and moderate glaucoma, a standard perimetry white on white is enough for diagnosis and follow-up. And we have been taught traditionally that changes in the structure will occur earlier than functional loss, which are seen on perimetry. This is standard teaching. Obviously, nothing in medicine is always true and always wrong and so on. Certain patients, you will find the field test will occur earlier than what you see on the structure. Certain patients, most patients, you will find the structural tests are seen earlier than on functional tests like perimetry. But standard teaching has been that structural changes are usually seen earlier than conventional perimetry. These are examples of a completely normal looking disc and field. This is an example of a disc hemorrhage in which possibly it is showing a change due to the glaucoma. The field is still normal. Here you see a classic change in the disc. You see a disc hemorrhage. You see an RNFL defect, but the field still is normal. So this is what we call as a pre-perimetric stage. Whereas you have a larger RNFL defect, you have a notch in the rim and a corresponding field. This is classic. At this stage, anybody can pick it up very easily. You see a notch in the rim, you have a field loss, you have a structural defect here. Whereas this is early, and this is what we need to be looking for when you are seeing your patients. Don't miss these subtle and early defects. These are all classic glaucoma. Why is that we are missing this so-called pre-perimetric glaucoma? Why are we not seeing this on perimetry? The reason for that is that only 6 test points in the central macular area that correlate to 90-degree segment of the optic nerve head is sampled in the 24-2 and 30-2 tests. The nasal optic nerve head is very poorly sampled, and 50% of the RGC, the retinal ganglion cells, mind you, are in the central 20 degrees, but yet we only have 12 test points in the Humphrey which lie here. So obviously, we are not testing enough in the areas which are important. That is why you are not seeing it. That is why we conveniently call it pre-perimetric glaucoma, because the test pattern does not allow us to pick up these tests. So this is food for thought, and the perimeter and the perimeter companies have been working on this. So I think the 24-2C is a step in that direction. We also have the Octopus G program, which picks up a little more of this information, gives more importance to the arcuate areas and nasal strip areas and so on. I will stop here and probably will take some questions and have some discussion. Most of what I said is already been published in our second edition of the book on practical perimetry. I invite you to have a look at the publication, which we have it in most of our libraries. Thank you for your attention.
It's a great presentation, Dr. Murali. Everyone is so thoughtful, and everyone would have understood much going into it. So there are a few questions coming up now. So I will post you a few questions. This is from Dr. Preethi. She wants to know whether we have to dilate all patients before perimetry and which algorithm to choose for disc suspects, whether it's 24-2 or 30-2.
If you are screening somebody for glaucoma suspicion or suspect disc and so on, for whatever reason, you want to do a quick test and you want to get the best out of the patient. So at 24-2, CETA standard would be the ideal test for, say, a first test for a patient, and give time for the patient to understand and do the test, and then repeat the test after. So if the field test is completely normal, then you probably don't have to repeat. If the field test is abnormal, then you probably repeat and take the second test as the test for follow-up and so on. And therefore, your question about the pupil dilatation. So in busy practices, we already start seeing patients with a disc suspect, already patients are dilated. So it is not wrong practice to do perimetry on dilated pupil. But you must make sure that it is not a shallow AC, a narrow angle closure. You have missed an angle closure and dilated the patient, then you will cut a sorry figure. So make sure there is no contraindication to dilatation before you dilate. And doing perimetry dilated is quite useful in our practices not to bring back the patient another day for doing the field test. So do the perimetry dilated, but make sure you do the dilatation and the perimetry with follow-ups also in a similar dilated group.
So the basic thing that has to be followed is just in like in medicine, a complete comprehensive eye examination is very, very important. That includes
Absolutely.
A dilated fundus examination.
Yes.
And you can post the patients for investigations, any investigation you want. And thinking on those lines, a dilated field is okay to be done, and you might not lose much of decibels in terms of picking up defects. So, and even a disc examination warrants a dilated, pupil. So, after a comprehensive or a complete thorough examination, we have to post these patients for investigation. So, a dilated perimetry is okay. Do we require, there's another question which says that do we require any gap between the tests of right eye and left eye? That's what I understood.
I think given our waiting time for patients, given the number of perimeters we have, even in busy institutions, we'll find we're limited by the number of machines we have, the number of patients waiting to do the test. So it is ideal to have both eyes tested on the same day at least. But sometimes what I suggest to patients is if you're fatigued doing one eye test, you do one eye, take a break, come back after 10 minutes, and let somebody else do the test in between, and you can come back for the other eye 5 minutes later. If they're fatigued, they can't sit through, they have spondylosis, they have back pain. So those kind of issues are there. Otherwise, some people do it in one shot. But a first test is generally a demo test or a test for scouting and understanding perimetry. So first test is not generally given too much of importance. Unless it's something like neuro-ophthalmology and you got a stroke and you got a hemianopia, then you don't need to keep on doing tests again and again.
When we're talking about neuro-ophthalmology problems, how about the head-mounted perimeters, the handheld perimeters play a role in picking up disease and progression? So what's your take on it?
Yeah, I think that the future probably lies in better models of this headset and virtual reality kind of headset mounted head without really needing to put your chin rest and having your forehead sitting on this expensive big machines occupying space. The future probably is in that direction. And but we have been seeing these perimeters evolve over time. And we still do find a lot of errors in testing. Early glaucomas and early suspects are not picked up at all. We find in mild glaucomas, many of these field defects are missed. Established glaucoma, we easily pick it up on the headset mounted perimeters. We sometimes find denser scotomas and the response buttons are sometimes not optimum. And comparison with normal database is somewhat questionable. So a lot of areas where the perimeters have to improve upon. But for an established glaucoma practice, glaucoma clinic, referral institute kind of practice, I would not recommend the virtual headset kind of perimeters. But if you're a single practitioner, you have practices where you cannot afford to have expensive equipment, but you need to do a field test for whatever reason. I think these perimeters are good. For just a general screening, for diagnosing, say, mild to moderate or moderate to severe glaucoma, established glaucomas, these perimeters are okay. But established glaucoma clinics, I think it's not really useful, at least at the current time.
The next question is, how do we assess the progression in a patient post-laser? What's your take on?
Laser in the sense, I'm assuming it is refractive surgery.
Retinal laser.
Retinal laser.
Retinal laser. Yeah.
So
progression in glaucoma.
Any intervention in a glaucoma patient, whether it's trabeculectomy, cataract surgery, YAG capsulotomy, or any type of intervention or change in therapy, actually means the baseline has changed. So whatever has been in the past is no longer used as a baseline. So you need to establish a new baseline after cataract surgery, after trabeculectomy, after retinal laser. We now have a new baseline. Based on the perimeter, the test which you've done after all this therapy has been done, the follow-up is based on the test you have done after the intervention. Obviously, the laser photocoagulation, however you do it with the subthreshold or threshold or even the new micropulse laser on the retina, you will still find there is some damage in the retina and the RGCs, and you will find a scotoma appearing on the visual field when the test is done. So it will actually confound our glaucoma test as well. In this condition, I'd probably look at more at the optic nerve, the neural rim, and also pay attention to the visual field, put all this together and establish a new baseline before we start using we cannot use an old field test for future comparison.
Will there be any impact on OCT, RNFL, or macular GCIPL thickness analysis in such conditions?
After the laser?
After the retinal laser.
Definitely, I think you will have changes in the retinal fiber layer measurement, and there will be a change. Again, the same thing happens is that we don't use it as a diagnostic tool. We use it as a tool to establish what is the current measurement, and we use the OCT, RNFL measurements for change over time. Rather than using it as a diagnostic criteria, we say, oh, no, RNFL is so much, we have watched this today and you have done some treatment, you watch for change over time, rather than looking at it as a one-time diagnostic parameter. And the GCC can be used for the OCT as well as the RNFL. I think it's a less used parameter for in the OCT when people are looking for changes in the RNFL. Also do the GCC. Suppose the macula is healthy and you're having a disc anomaly or a high myopia, peripapillary atrophy, optic nerve changes, whatever, for some reason you're not able to get a good RNFL measurement, use the GCC provided the macula is healthy.
And another question is about the gaze tracker and interpretation for reliability, fixation loss, and all this. So,
the gaze tracker is another indicator of reliability. If you look at the advanced machines or the Humphrey 740 and 750 and the newer 800 series machines, will give you the gaze tracker at the bottom. The gaze tracker will tell you as the patient been following and fixating on the stimulus, so on the fixation target, and while the test is being done. So if you look at how reliability is actually tested by this blind spot monitoring, and I'm sure many of you understand what is called as the Heel-Krakow monitoring of the blind spot. Periodically, the say about 1/5 of the stimuli which is used for testing overall is thrown on the blind spot, and the perimeter randomly throws this on the blind spot. But suppose between the test estimation of the blind spot using this Hale-Krakow method, patient can actually lose fixation. It's not a continuous real-time monitoring of fixation loss which goes on throughout the test, which is why the gaze tracker actually gives us information about is the patient losing gaze, losing fixation, and so on. Suppose you find everything is going haywire in the bottom of the field, you will find that the patient has actually not done the test well, and you can re-instruct the patient and get the test repeated if possible.
A question from my side. As we plan for surgery in most of the patients with advanced glaucoma, what are the most important things we have to order in a field analysis test, which also mounts for medico-legal opinions, or sometimes, to explain to the patient what we have to look for, what will be the outcome of the patient after surgery, especially in one-night advanced glaucomas.
Extremely important parameter and a very good question, Vijay. I think this has to be understood by every one of us who practices modern medicine and glaucoma and ophthalmology. That documentation is the key element for us to be successful and safe in practice. You have to document all the clinical findings like visual acuity, intraocular pressure, gonioscopy, disc findings, and so on. But the patient's subjective visual field is very important. You need to know what is the visual field status before any surgical intervention. As far as unless you have a total cataract and visual field cannot be done, even then you can document it by doing some kind of a confrontation perimetry, projection of light, PR accurate or not, projection of light, and so on. Do the visual field at least a 24-2 CETA standard. And suppose you find the fixation and the central field is getting affected in the central 10 degrees, close to fixation, you must do a 10-2. A 10-2 has to be done, if possible, even a macula program as well. But the minimum would be a 24-2 at least, and a 10-2 on top of it if you're doing a central visual field. Look for the split fixation. Anything which involves the central 5 or central 10 degrees visual field, it has to be documented. If you find a split fixation, the prognosis changes, and always the fear about split fixation and losing central vision is there, especially one-eyed patients. Document the disc changes, document the visual field, and document the 10-2.
So the answer for such patients is do a 24-2, 10-2 macula for safety reasons.
Absolutely. There's no doubt.
It
has to be done. Yeah. Has to be done.
And another question which has popped up is if there is a borderline glaucoma hemifield test, few depressed points here and there on 24-2, OCT comes normal, the IOP is around 20. Do we plan treatment, or when should we?
See, glaucoma is a disease which doesn't blind anybody within the next few days. It's a slow progressive disease. Suppose you have what they call as a suspect. As a glaucoma suspect can be because of intraocular pressure being something like ocular hypertension 28-30, and the optic nerve still looks normal. It's an IOP suspect. You can have a narrow angle and you have angle closure with the disc being normal and IOP being normal. So it's something like a gonio suspect. Then you have what is called as a disc suspect, and the disc looks like glaucoma. Most of the time, we overdiagnose glaucoma by looking at the disc, and especially large disc, large cups, large vertical cup dysplasia. We always overdiagnose glaucoma and disc suspects. So glaucoma suspect, you find something in the optic disc and you have a visual field change. Patient is still has 6/6 vision, pressure of 20. Nothing is really going to happen if you wait for a few months, but make sure the patient is monitored closely. Check for the intraocular pressure, do the gonioscopy, document the optic disc photography, look at the RNFL and the visual field, and make sure you repeat the test after some. Don't be in a hurry to treat. A 20 intraocular pressure is not going to blind the patient the next few weeks. You have some time. If possible, repeat the test in the next few months and check if it's a repeatable field effect.
So the armor of treatment in glaucoma is follow. So always
Absolutely. Follow-up
before
is the
treatment.
key. And don't forget to properly see. Managing glaucoma is not only treating glaucoma. Managing glaucoma is asking the patient to come back after 3 months, come back after 6 months, check the intraocular pressure, do a gonio, come back for the visual field. That is all. Doing nothing is also management, but asking the patient to come back and report for follow-up.
Another question which has popped up is in a case of suspected NTG or an NTG bar neuroophthalm, is there anything which a 10-2 field can give apart from obeying the vertical meridian?
A 10-2 is not going to add too much of value for a neuro-opthal test. No harm in doing a 10-2, of course. First, if you're looking at something normal in the 24-2, then a 10-2 will going to help. But you already have some field effect on the 24-2, unless it's a glaucoma patient and you're really looking at some surgical intervention or something, a 10-2 is not really going to add value for neuro-ophthalmology. But if you really have a doubt about, say, something in the central visual field like a drug-induced scotoma or something in the neuroophthalm in which tells you that there's a central visual involvement, then a 10-2 would definitely help. A macular program also would help. But a 24-2 is by and large enough for most neuroophthalmic conditions. The 30-2.
Is there a need to explain the VFI, visual field index, to the patient?
I think it's better not to get into the this trap of explaining that your visual field is 80% normal or 90% normal. Patient will stick to that and start looking at the charts and start questioning you every time the field test is done. If you want to remain non-committal, we also don't understand all aspects of glaucoma and perimetry. So by trying to be over smart and explaining that you have 80% normal or 60% glaucoma. So I think better not to get into that and leave it as it's a mild glaucoma, it's a moderate glaucoma, severe glaucoma. You classify that and say that you need close follow-up, you need what. Don't get into the nitty-gritty of every aspect of perimetry unless they are a perimetry expert or something. It actually makes your life more difficult. So it's better not to get into the finer nitty-gritty of, for example, trying to explain an MRI to a patient or trying to explain ECG to a patient. We don't do that. We simply say normal, abnormal, this is doubtful, and we'll get an opinion. And leave it to the expert and the technical expertise, and don't get into explaining every aspect of what we understand to the patient. It's not needed, I think.
Another question which has come up in the paradigm of pre-perimetric glaucoma. So what you suggest as far as perimetry is concerned, testing, and about the OCT RNFL, is there any role of HRT and GDX?
I think GDX is no longer available and GDX is completely gone. And HRT also is no longer available as all the machines have all gone away. HRT3 also is not there. You only have what is called as the hybrid kind of CSLO OCT technology called the Spectralis now. Spectralis is still available and is an extremely good way of looking at the structural aspect of RNFL, and it also looks at the BMW and the basement membrane. So many parameters which the standard OCTs don't give, the Spectralis does. And with regards to your other question about perimetry, I think we should stick to 24-2 as the default testing strategy. In occasional patient, you can also do a 30-2 if you feel a younger patient can spend more time, do a 30-2 as well. With as far as imaging is concerned, the RNFL, OCT RNFL is the standard for most of our machines, Topcon or Zeiss or any Nidec or any other machine. Spectralis has got a slight edge in terms of measurements for future comparisons. So Spectralis seems to be a little more expensive machine, and some of us, I think, use it in our practices as well.
What are your final comments on photoperimetry in this World Glaucoma Month to the large audience?
I think there is some misconception that glaucoma can be screened by perimetry, glaucoma can be screened by intraocular pressure. Let us do a camp and glaucoma camp and call in the general population and start looking at glaucoma in the population. Let's pick up. So I think screening we have to understand that only when there is a high prevalence disease, a screening strategy in which you have one single parameter for glaucoma diagnosis. For example, you want to screen for diabetes, you can look at blood sugar. You want to screen for blood pressure, you look for hypertension, you look for blood pressure. In glaucoma, we don't have a single parameter for diagnosis. So we need to have data like intraocular pressure, the gonioscopy, the optic nerve findings, and so many parameters. So screening for glaucoma is not worthwhile in the general population. That is the take-home message I think we should convey in the glaucoma month. And if you really want to sincerely screen for glaucoma, look at the high-risk individuals. High risk means like somebody who is like elderly, family history, old trauma. Like we've been putting in all our posters and brochures about screening high risk individuals, especially siblings and relatives of glaucoma patients. Every patient with glaucoma whom you see today in your clinic or practice, established glaucoma, make sure that their relatives get screened. Their siblings, their sons and daughters, their brothers and sisters. That is a way in which we can improve, of course, our search of practice volumes. And also you have a better yield because you're going to directly target patients who are already established to have found to have glaucoma. Don't go shooting in the dark, and you will find you shoot in the dark of 100 patients, you'll probably find a prevalence of 2%. Whereas you hit a target of glaucoma established patients. Even the Arvind paper from Pondicherry showed that screening siblings for angle closure disease will give you a much higher yield than simply shooting in the dark.
That's final word. Thank you very much for your presentation, sir. We sign off now. Thanks for all the participants and the management team. Thank you very much.
Thank you, Dr. Preethi and the Clinical Education Board for giving us this wonderful platform to discuss things. And Vijay has been a wonderful panelist, and he's himself a senior glaucoma specialist. And thank you for anchoring this program.
Thank you so much, sir. Thank you, Dr. Vijay Anand also. Thank you.
Thank you, Dr. Preethi. Thank you.
Thank you, sir. Bye.
Thank you all for attending.